Good morning and welcome this morning here at Carmanos. We have a talk lined up for you with Dr. Jeffrey Zonder. And my name is Melanie Wiedmeyer, and I welcome you all on behalf of the Cure Multiple Myeloma Corporation. And Sid's here with us today too, its founder. And we are happy to do these discussions to help patients get more connected with doctors that are experts in the field of multiple myeloma. So thank you for coming today. Those of you that are here in person, welcome. Those of you on Zoom, I welcome you as well. I ask you that you mute yourself. If you're not already muted, if you could please mute yourself so that there's no background noise. But if you want to ask a question, you'll need to unmute and ask your question then. I want to just go over a couple items before we start. We have 3 more Ask the Doctor discussions coming up after this one. You can sign up for those on our website listed on this page, curemultiplemyeloma.org. Don't forget too, we have Wine and Dine in the D scheduled this year for Wednesday, November 6th at the Weston Book Cadillac, and we invite you all to watch for that and save the date. And lastly, before we start, I want to thank all of our sponsors that are here too and that are also attending via Zoom. Without you, we couldn't put on this nice breakfast and all the technology that we have, and of course, what it takes to put on these meetings. So thank you to our sponsors. And without further ado, I'm going to turn it over to Dr. Zonder, and he's going to do a quick update on himself and then we'll open the floor to discussions.
Okay. I hope everybody can hear me okay. I think as is usual for me and also for these breakfasts, there's not a slide presentation or anything like that. The idea of this is that we're having a conversation. There's people in the room who probably think I'm talking much too loud right now, but I want to make sure that people on Zoom can hear also. And the idea is going to be to let you all drive what we talk about. I'm happy to talk about any myeloma or amyloidosis related topic, whatever you are interested in. And that includes precursor conditions, includes therapies, it includes symptom management, whatever you want. I mean, we can cover anything. In terms of, I guess, an update for Carmanos and the Carmanos program, just so, we have nice things happening. We continue to be an active member institution of the Multiple Myeloma Research Consortium and Foundation. Their research focus over the coming years is a trial platform called the Horizon trial, which is what we call a basket trial, meaning there's different regimens it's a modular trial where different regimens are being tested and compared to one another and to standard therapy. And there's an upfront newly diagnosed sort of high-risk myeloma part of this trial, and then there's a relapsed refractory section of this trial. And as you might guess, the regimens and strategies that you're exploring for those different situations are different, right? And so that's an ongoing effort. And one of the members of the Carmanos multidisciplinary team, Craig Cole, who we have a very close working relationship with, and who has been seeing patients with Carmanos in the Lansing area. He is actually the National Diversity Officer for this protocol. The goal of that is to make sure that across the entire conduct of the trial, that we're doing everything we can to make sure that enrollment on the trial is representative of the patients who are the people who are actually affected by multiple myeloma. As we know, it is a disease that disproportionately affects African-American people. and Carmanos will continue to do what we can to make sure that trials are available to all of our patients and all patients around the state of Michigan. In terms of other big news, I would say the other interesting thing recently, and then a focus that Carmanos is interested in, the NCI when recently sort of acknowledged MENA people as distinct ethnic and group. MENA is Middle Eastern and North African, and until recently, that's never actually been any part of any sort of demographic analysis of any studies being done in cancer. When you read articles, it will report like, this is the percentage of African-American patients, this is the percentage of Caucasian patients, this is the percentage of Asian patients, but Middle Eastern patients and North African patients as a group were never, but they were sort of just folded into other groups. And now that is no longer the case, and they expect cancer centers and cancer researchers to report on this subset of people, just as they do on others. And I think the Carmanos Cancer Institute is actually going to be a leader in that. I mean, this is something we've obviously with our Metro Detroit MENA population, we've been interested in this for a long time. We already have a track record of publications in this area, even before this mandate by the NCI, and the myeloma group recently has been meeting to actually launch a project specifically focused at the natural history of the disease in this group. So we're enthused about that change. I think it's about time. So that's my update. So what I want to do, I'm going to stop talking, let you guys talk, and tell me what you want to cover today. So anybody could unmute, or anybody in the room can just fire away. Probably if you can't all see each other online, there's a way to like virtually raise your hand, right? Is that right? Yeah. And yeah,
We have a couple of questions here too.
yeah. Okay.
Want to start with this one? Can you read it from there, or would you like me to read it?
Will PERMGARDA be available at Carmanos? And the answer is I don't have information on when that will be available at Carmanos. I will see what I can find out, but
What is PEMGARDA?
I want to make sure that I say this correctly. I don't want to get this wrong. Apologize.
What is it?
It's a new COVID-19. It's like it's like the monoclonal antibody Evusheld that we were using just a few years ago, right? And it was we were using that I think with benefit in patients with myeloma, because myeloma patients often don't respond very well to vaccination. And so, we did a study where we looked at antibody levels in patients who had been vaccinated, and actually a huge percentage of our patients weren't generating antibody responses, although there was evidence of other types of immune response, like T-cell responses. Like you could distinguish between patients, for instance, who had been vaccinated and who had been exposed before. It was possible to distinguish between those patients, even among the patients who didn't have antibody levels, measurable antibody levels. So we had this whole patient group that, basically, the world was opening back up, after COVID, and we had this whole patient population who felt still pretty naked in terms of protection. You know, people are vaccinated and going back out into the world, and then myeloma patients were vaccinated and didn't have antibodies and weren't going back out into the world. And so Evusheld was basically a passive antibody treatment. And it was very useful and protective against the strains that were circulating at the time it was in use. And then after about a year of use, the strain shifted and it was no longer protective against the strains that were actually causing infections. And so it was withdrawn from the market. And so Premgarda is like Evusheld version 2. You know, that's the idea of the antibody. It's but I don't know. I don't believe anybody at Carmanos has received it, and I don't know Hal and others who asked. I think Hal and was it Terry?
Jerry.
Terry, yeah, Jerry. I think two different. Yeah, I don't know the answer to this question. I will try to find out.
For individuals who've received a transplant followed by vaccination, is it worth getting antibody levels to see if they've responded to the vaccines?
So, I think it's, I think we know for most people, you know, we have a general sense of how they're likely to respond to vaccines based on their IgG levels in general. If you're chronically, profoundly hypogammaglobulinemic, like if your IgG levels are very, very low, less than 600, your immune response to things is blunted. Again, antibody levels alone didn't tell the whole story. So, you know, in terms of specific, like response to specific vaccination or protection against a specific type of infection, we don't routinely do that. But we do routinely consider the use of IVIG in patients who have very low IgG levels to just sort of broadly, passively immunize patients. So I don't know. I assume does everybody know what IVIG is? So IVIG is sort of like, think of it like a blood product in a way. When we talk about immunizing people, there's active immunization and passive immunization. So an active immunization is you give somebody a vaccine and it stimulates their body to make antibodies. Okay, so their immune system is actively participating in that, and we're just giving them something to help get their immune system revved up. For somebody who can't have that robust response to a vaccine, we can passively give them antibodies that are protective. Their immune system doesn't have to do anything. We can just give them something that helps protect them from an infection. What IVIG really is, it's like if you went out into the waiting room and you skimmed the antibodies out of everybody's blood in the waiting room, right? I mean, and you put them in a bag, those antibodies, what would you have? You'd have antibodies against measles, mumps, rubella, strep, flu, COVID. You know, you'd have antibodies against pretty much everything you'd want antibodies to if you pool enough people's, right? And so, there are, several companies that make IVIG. It's given generally as a monthly infusion. It keeps antibody levels at not just at a protective level, because it's not just the level, it's also the sort of the spectrum of antibodies that are in it, right? That's what's protective. And it has been shown, particularly in the recent era with bispecific antibodies and CAR T cells, where like these BCMA targeted therapies, I mean, just shut down antibody production to like nothing. Almost all of these patients are very, very, very low antibody levels. One of the groups, I think Mount Sinai in New York, they did a retrospective look at their data, and the risk of antibiotic or hospital requiring infections was knocked down by something like 80%, when they just started giving IVIG across the board to patients getting these newer therapies. So it is helpful. In the past, with less immune suppressive therapies, it was a little bit harder to demonstrate the benefit of IVIG. So, it's been available for decades, but it wasn't really in heavy use until recently. And now, again, with these recent therapies, the need for it is, they're clearly demonstrated for some patients. Lisa online has a question about the results of recent CAR T therapy. So there were there's been a recent sort of like shift in the landscape completely. CAR T therapy previously had been approved for patients who had had 4 lines of prior therapy, both ide-cel and cilta-cel, which are Abecma and Carvykti are the brand names of those. And based on clinical trials looking at the effectiveness of these therapies against standard of care options, strongly positive results for both of these led to moving the approval up. So they expanded the approval, and now cilta-cel can be given as a second-line therapy, and ide-cel can be given as third-line therapy. And both of those fall way in front of bispecific antibodies, which are still currently approved for that original 4 or more lines of therapy. So it's it's going to be very interesting to see how CAR T cell ends up being used. For patients with earlier with relapses, like a first relapse, second relapse, like that's, I think there's going to be a lot of interest in that. I'm not sure, obviously, for the majority of myeloma patients who get transplanted, it's done as first-line therapy or as part of first-line therapy. So it's not going to immediately like supplant transplant or anything like that. Although I do think, my opinion, right now, I think for the last 5 or 8 years, I think an increasing number of patients have been deferring transplant to second-line therapy. They're on a regimen that's working, DARA RVD or RVD or DARA RD, like they're on some good first-line regimen. Disease is well controlled. Side effects become very predictable after you've been on it for a while and you sort of know how to manage what's happening. And a lot of patients are deferring transplant because they now know what to expect from what they're getting, and it's working very, very well. I suspect those patients with CAR T as an alternative to transplant, I think, that was not one of the standards of care that it was compared against in these trials that led to the expansion of the indication. But I suspect it's going to a lot of patients who defer transplant are actually going to end up just, not ever having a transplant. That's my guess, but we'll see. We'll see. But it's exciting times. We're very happy to have these agents available earlier. That the difference between being able to give CAR T in second or third line compared to fourth line is huge, because that third and fourth line of therapy, those are sometimes challenging. Like there's a significant drop off in terms of what you expect out of regimens as you move through therapies. And first, second, and third line therapy generally works quite well. But if you're trying to wrestle disease control later, it's much less predictable. We still have good regimens. We still are able to do it, but just in terms of like going into it with assurance that you'll be able to do it, it's not as certain. And it's going to change, I think, not just when we use CAR T or what we get out of CAR T. I think it's going to change the likelihood of, after a referral for CAR T actually ending up getting it. Right, because a lot of patients in the old original approval, a lot of patients, like if if that line of bridging therapy that they were getting while they were trying to get to CAR T, if it didn't work, sometimes they sort of spiraled out of contention for that treatment, right? And then you lose access to it. And I think that's gonna not happen very often at all when you're using it earlier. I think, so it should be a major improvement in the use.
So how long does the CAR T is it effective? Like, is it 1 year, 5 years, 10 years?
More than 1 year, less than 5 years on average. The interesting thing, the interesting thing is that in these earlier trials, CAR T pretty soundly beat up on standard of care therapy. Like CAR T was clearly better with both products than what it was, the standards that it was compared to. But it wasn't clear that it worked dramatically longer or better than it did when you used it later. That to me is actually a pretty interesting aspect of it. I would have expected it to be dramatically better, because for most other regimens, like when you think about standard chemotherapy regimens, always better when you use them earlier. When you use regimen X as first line therapy, it works better than if you use it as third line therapy on average. CAR T, there is less of a pronounced difference there. I tell patients to expect to get 1 to 2 years on average out of CAR T. The nice thing is without maintenance therapy, other than IVIG for some people. You can fine tune the answer a little bit based on the degree of response they have to CAR T. So if you're somebody that has a partial response, and that's not even right. If you're somebody who has less than a minimal residual disease negative response, meaning some test that we have available can find myeloma cells after treatment, those patients don't do the same as patients who go into that super deep response where you can't find the response, or can't find the residual myeloma.
So once you relapse on CAR T, can you get another CAR T? Is there any
There's all sorts of data. The answer is yes. The longer it is, probably the better. You can also switch back and forth from CAR T to bispecifics or bispecifics to CAR T. There are different ways that myeloma can get around CAR T cells, and some resistance mechanisms pose a bigger problem than others in terms of retreatment. Also, right now, all the CAR Ts that we have available have the same target, BCMA, but that's going to change over time. Just like we have bispecifics with different targets, we're going to have CAR T cells not that far in the future with different targets, and that will probably change what you get out of retreatment with a second round of CAR T versus, when you're shifting the target. Yeah.
Do you think in the future stem cell transplants gonna decrease substantially?
Oh, I'm sure it will decrease substantially, but the honest truth is, what we get out of CAR T cells right now is not like so far, transplant remains an important therapy. It's
Still recommended?
we do. When you look at the likelihood of getting to that, I mentioned it already, minimal residual disease status, right? That's using commercially available tests to find like 1 myeloma cell out of 1 million cells in your bone marrow. The likelihood of getting to that super deep response level is higher with transplant. And the statistical likelihood that transplant will be the difference in getting to that super deep response rate is highest in high-risk patients, meaning, to drag patients with the high-risk cytogenetic features that we worry about, like the deletion 17, the gain of 1Q, those patients, without transplant have a lower rate of getting to that super deep response rate. And so transplant makes the difference for them disproportionately. So we do, we recommend it. So far though, if we're being as objective as possible, We know that it induces MRD negativity at a higher rate. We know that that translates into longer disease control with first-line therapy on average. But what it doesn't translate into is longer survival. And that has to do with what I said before about second-line therapy works, third-line therapy works. You know, and when your combined expectation for first, second, and third-line therapy is now over 10 years, you're not going to see a survival difference in the first 5 or 8, right? And so, that's the strongest rationale. When a patient looks me in the eye and says, I'm really not interested in transplant. I mean, if it doesn't improve my chances of being alive 2 years from now, 3 years from now, 5 years from now, that's correct. That's a personal preference, so we'll see if it. I think as a field, particularly for high-risk patients, we're seeing a shift in the thinking about the importance of getting to MRD negativity and, transplant to help get you there, or consolidation after transplant to help get you there. I think that's kind of a moving target right now. And when I talk with my colleagues around the country about this, everybody's all over the place right now. Like, should we be treating to MRD negativity? Is that now the treatment goal? Should I recommend transplants universally for patients who aren't MRD negative? At that time point, should I recommend post-transplant therapy that's more intensive than standard maintenance if they haven't achieved that? There is no agreement nationally or internationally about this right now, but we're trying to sort this out.
What the cost of CAR-T?
Cost of CAR-T is very, very expensive. It's 5 times as much as stem cell transplant. So it's, from a cost standpoint, it's not trivial, right? It's real. I mean, and for the healthcare, for our healthcare landscape, it's real. So
Is it covered by insurance?
it is. It is. You couldn't really consider the therapy without, if insurance did cover it, right? So it's prohibitively expensive.
Speaking of insurance, going not CAR-T, but what about individuals who do not qualify for assistance for either Revlimid or Pomalyst, which can be $12,000 a month, and they don't qualify for assistance, but they're still relatively low income and therefore can't afford it? What happened? How are they treated? Who takes care of them?
Right. So I think you're touching on, for people online who couldn't hear, the issue is, having just enough resources to not qualify for assistance with oral meds, but also not really actually being able to afford the oral meds, right? Which is not an uncommon scenario. So there are a lot of assistance resources available. Also, Michigan has taken a step forward with drug parity recently. I mean, this last year, although it hasn't, I don't believe it's actually gone into effect quite yet, but it's, the drug parity is an important, just in principle for cancer therapies, basically that oral medications need to be covered the same way you cover non-oral medications, right? Which has not always been the case. Usually from insurance companies, IV and sub-Q medicines are paid for out of one pot of money and oral meds are paid for out of another pot of money. And most people's policies have differences in what you're responsible for, related to those, right? Copays. A 10% copay of or a 5% copay of a medication that costs $100 is one thing. But if it costs $100,000 a year or $500,000 or something absurd, right? Then that's prohibitively expensive, even if you're only paying that small percentage. So it's gonna change. The way I don't quite remember the details of the parity law, but there's like a cap, an annual cap on what you'll have to shoulder. And then it's covered after that. So it will make a big difference for patients in Michigan, but it's not quite happening yet.
when a patient undergoes a stem cell transplant, enough stem cells are harvested in the event that another one is needed somewhere down the line.
Yeah.
So if CAR T becomes third or even second line therapy, would that mean in the future there'll be fewer second stem cell transplants for the same patient?
They're all, so the question was about usage of second stored bags of stem cells and second transplants. And is it anticipated that second transplant rates are going to go down? The short answer is they've already been going down. As therapy has gotten better and better and better, the use of those has gone down a lot. Last time we looked at it and published it, I don't know. I don't know if the transplant team has looked at usage lately, but the last time we published anything about it, only about 30% of our patients who had a second bag of stem cells ever used them for a second transplant. Last year, Ohio State took a look at their data, 5%. You know, so like, you know, they have all these stem cells stored, you know, basically for everybody because it's a very standard practice, and then 95% of them never get used. I think what's gonna happen though, I think we're gonna repurpose those cells. I think you know what an increasingly common use is in patients after CAR T cells who have like these prolonged immune mediated low blood counts. That is actually one of, you know, there are several specific complications from CAR T cells. One of them is protracted low blood counts, even though you're not getting ongoing therapy, but like low blood counts like you have when you're on chemo. Using that bag of stem cells to sort of replenish the bone marrow and try to overcome that has been used with some success. We've actually used some bags of stem cells for that purpose, and I think that's happening at other centers as well. Yeah. Question from Jerry: will Dr. Cole be seeing patients at Carmanos in the Detroit area? Yes, he will be. Well, I mean, that is the plan. I mean, right now, we're getting that in place. It's anticipated that it's going to be later this spring or early summer, but he's going to continue to see patients in Lansing. He has a busy myeloma clinic in Lansing, but yeah, we're happy to say that it looks like he's going to be practicing downtown as well, a couple days a week. That's the plan. You know, until his clinic opens the doors, I'm just going to remain with my fingers crossed that the whole process continues to go smoothly, but that seems to be where we're heading. So very exciting. We're couldn't be more excited.
I had one question that was emailed to me, and I think you've hit on it all the way around, except for maybe she says with all the amounts of treatment and investigational drugs available on the market today in the United States, at what point does bone marrow transplant become necessary?
Again, it's one of those things. It's, you know, in terms of necessary, I view it as a helpful line of therapy. I think if you're going to use it, I think using it in first or second line therapy makes the most sense. I think the longer you go, if you don't have stem cells stored already, the harder it is to collect those stem cells. But also, you know, stem cell transplant is really, it's a misnomer, right? Really, it's just a very high dose of chemotherapy. And so you get the most out of that one high dose of chemotherapy when your myeloma hasn't evolved all sorts of acquired resistance to treatment. And we know that we get less average mileage out of a transplant when you use it later. And also, you know, the things that I think make people worry about going through a transplant, you know, the toxicity of high dose therapy and the downtime and the fatigue, you know, it's a little bit of a self-fulfilling prophecy too. I think, you know, if you do your transplant when you're already pretty run down with pretty resistant disease and, you know, 10 years older than you were the first time you talked about stem cell transplant, it's going to be harder. You know, and you know, like I said, it's a self-fulfilling prophecy. It's going to live down to your expectations if you know, wait and wait and wait and wait.
Like, where'd your mama have put it? Oh, here.
So, I think somebody, yeah, so, all that said, though, I mean, technically, there's no age limit, for transplant, right? I mean, it's more about physiologic health. So if you're physiologically healthy, we'd rather have an 80-year-old who looked 65 than a 65-year-old who looked 80, right? I mean, clearly, that first patient is a better transplant candidate than the second patient. We prefer to have somebody whose myeloma is still responding to therapy. It just predicts that they'll get more out of the chemo. So there's no hard, fast line, but there are patients who are better candidates than others.
When does the fatigue after a stem cell transplant and then go through your
Variable.
maintenance procedure? When should you start seeing fatigue and I mean,
It's variable, and I guess it depends a little bit on sort of what the maintenance itself is doing, right? The recovery from transplants, I think the transplanters will tell you that on average, you'll feel like yourself after 3 to 6 months, like really like yourself. I've had some patients who, are like, 30 days after transplant, they're like, please let me drive. I want to go back to work. Some patients really recover quickly. And then I have other patients who it takes longer. The transplanters will tell you on average 3 to 6 months, but be prepared for the possibility of a year. That's, the maintenance therapy though usually starts about 3 months, right? 3 to 4 months after transplant. And so, if the usual maintenance is Revlimid, lenalidomide, any therapy, even lower intensity therapy, can nickel and dime people, right? Usually maintenance, because you're thinking about doses that are 10 to 15 milligrams, sometimes as low as 5 milligrams. That's lower than what you use when you combine it, with Velcade and Dara upfront. When you're using 15 to 25 milligrams, you're not using it partnered with other agents in the majority of cases. There are some circumstances where we like to, but it's still not being on nothing. I mean, it's, and fatigue, fatigue is one of those very hard to quantify side effects from any therapy, understanding the impact of long-term low-grade side effects is not something the oncology community is very good at. We're starting to get at it with like patient-reported outcomes measurements, but it's just getting traction, that idea, about quality of life and what scale should you be using and how do you interpret it. But, it's, everybody understands, like this, I say this to patients all the time about, lenalidomide specifically, right? Like everybody understands what it means. Like if you roll into clinic and you say, yesterday I started having diarrhea and I've gone 7 times today and 7 times yesterday, and everybody understands what that means, right? And hopefully, in a few days it's viral gastroenteritis and it goes away and you're through it and it's in the rearview mirror and you just say, yeah, that was a bad bout of diarrhea. What does it mean to have like 1 or 2 episodes of diarrhea every day for 5 years, right? I mean, that's a whole different thing, right? And it's in terms of what does that mean in somebody's life? What does it mean to be, not necessarily sleepy, but fatigued, not able to do the things you want to do every day? Like it's hard. It means different things to different people. Hopefully that is like seasonal.
What about appetite suppression after stem cell transplant? How long does that typically last? Does it vary just completely between people?
In my patients on Wegovy or not? No, I'm just.
Is it caused by the antibiotics they're getting during that 100 days?
I think it's a lot of things. I mean, there's real GI toxicity during chemo. There's some of the supportive care meds also, can affect appetite and how dry your mouth is and how food tastes. Again, maintenance therapy can affect how food tastes. That leads to some appetite suppression for a lot of people. So it's variable, but it's real.
Okay, and how do you know when that it really needs to be addressed? I mean, this person's gone back a couple of times for post-transplant. It has lost weight every time, but even now after 35 days, really like
After how many days?
35. I mean, it's still early, but
I'm not, if they're losing weight, they're not getting enough calories, right? So, I mean, it needs to be addressed now because they're at a calorie deficit. But in terms of like, am I worried this is going to necessarily be like a super long-term thing? Not yet. 30 days, 35 days, that's still, I mean, you know, if you think about even about like standard non-transplant regimens, right? I mean, they're in 3 and 4 week cycles, right? You need the 4 weeks, you're part of what's built in is recovery. I mean, that's non-transplant therapy. So 35 days, that I think you can still see a resolving GI toxicity for 35 days.
okay. And do you see any difference based on race?
That's an interesting question. In terms of side effects from
Yeah.
transplant? So there are some statistical like baseline differences between like white blood cell counts and hemoglobin in African American people versus Caucasian people. And there's a genetic basis for that in most cases, actually. And it's not, so there is a difference in the rate of those kinds of like low blood count issues in non-transplant therapy. You know, if you're starting here in one group and starting here in another group and they both dip about equally, one will dip lower and sometimes run into those ranges that we start getting concerned about where we're at. Transplant's kind of an equalizer though in that respect, like everybody's counts kind of bottom out with transplant. So, you know, it's not obvious that there's a major difference in terms of GI toxicity, blood count issues, infection rates. Those are not really. There was, we published on this, we had an abstract at ASH. The Dana-Farber determination study was a national study that Paul Richardson headed up, and Carmanos was one of the major participating sites in it. And we looked at outcomes in African American people versus non-African American people. The interesting thing was that in the transplant group, outcomes were actually pretty much the same. The interesting thing that we found was that in the group that was randomized to delayed transplant and just got through, the study was RVD induction with or without transplant as part of first-line therapy. That's what the determination study was. And in the group of patients who were randomized to transplant at some undefined date later, not as part of first-line therapy, African-American patients actually did better as a group than Caucasian patients did in the non-transplant arm, which was interesting. We looked at specific, we looked at age and gender and body mass index, and there seemed to be more variability in how African-American patients did based on those different factors. And so we're trying to tease that apart. The other thing that we're in the process of doing right now, and that's ongoing work at Nikhil Munshi's lab in Boston, is looking at like the contribution of like inflammation levels and immune microenvironment, things that absolutely could vary according to ethnicity that we don't normally measure. Like there's not a great clinical measure of, but we know that inflammation, differences in inflammation, for instance, contribute to the risk of atherosclerotic heart disease in African American people. We know that that's true. So we're interested to see if that ends up being something that's also, contributes in myeloma right now. That's ongoing work, and we're looking forward to those answers.
What's the incidence of true non-secretors and how do you follow them? And what alternative ways to follow them?
So the question was non-secretory myeloma. The incidence right now, honestly, is 1 or 2% of myeloma cases. I mean, once you've, when somebody seems to have myeloma and doesn't have a good blood marker, once you've done free light chain testing and once you've checked IgD levels and IgE levels, almost all patients have some marker to follow, but 1 or 2% don't. And it's hard. When I was in training, when I was a fellow and a brand new attending, we didn't have free light chain testing, right? So the incidence was like 10% or 5%. It was, it was a much more significant number. And on top of it, we didn't have PET CTs. So our imaging was inferior at the same time. We had, a higher percentage of patients we couldn't find a marker on and bad testing, bad imaging. PET CTs have really, and whole body MRI, both have really changed the way non-secretory patients can be managed, because unlike just a straight CT, you're not just seeing a snapshot of how big a lesion is, but you're seeing how metabolically active a lesion is. And so you can tell the difference between a treated cold lesion that, probably isn't going to get any bigger, if you keep doing what you're doing, versus a lesion that very well might get bigger because it's just not controlled, right? So serial PET CTs, the way we manage like lymphoma patients, that's right now the best way to do it.
How frequently?
I generally do it every 3 to 4 months, or maybe every 6 in a person who really has no symptoms at all, but I wouldn't do it less often than that myself.
You do bone marrow as well?
It varies. If a person's blood counts are perfectly normal and their calcium and kidney function is perfectly normal and their PET scan is ice cold, not necessarily. I think there are some, but with all of those, if yes, plenty of patients get periodic bone marrows as well. I mean, a bone marrow is a gold standard way of, looking at someone's myeloma. It's just the least pleasant way of looking. Right, so, but yeah, I think there's a lot of variability, but frequent imaging and periodic bone marrow biopsies is probably the way most non-secretory patients are managed over time.
I have a 2-part question for you. What types of secondary cancers are you seeing associated with multiple myeloma or caused by medications? It's the first question. The second is, when there's a diagnosis of a secondary cancer, is there ever conflict in between the treatments that each of them would go through?
Absolutely. So secondary cancers are a real issue in myeloma, and actually they have been for a long time. I mean, the incidence has gone up in part because of the agents that we use to treat myeloma, but also because the agents allow patients to live longer than they ever lived before, right? And so, the 10-year rate of secondary cancers is a much more meaningful thing to have on your radar screen in 2024 than it was in 2004. Back then, 5% of patients lived 10 years. Now, half of patients, and more than half of patients, if you have standard risk disease, live more than 10 years. So it's real. I mean, you have to, keep an eye out for that. The classic group we worry about is patients who are transplanted early and then have lenalidomide maintenance. Like that the incidence we have pretty good data that the 10-year incidence is in the 8 to 10% range. The absolute increase in risk of solid tumors like lung cancer and colon cancer and breast cancer, if it's higher, it's minimally higher. The incidence in non-melanoma skin cancer is higher. And then we worry a lot about, there seems to be the biggest increase in hematologic cancer. So like secondary, like myelodysplastic syndrome, AML, ALL, there are some cases of Hodgkin's lymphoma, like, I mean, you know, so we see these and, you know, I mean, you know, I mean, you know, the competing risk of myeloma throughout a myeloma patient's life is always higher. At any time point along the entire journey, the risk of myeloma coming back and becoming like a life-threatening issue is always higher than the risk of a second cancer statistically. And focusing on that, you know, I think most of us are sort of like, you know, glass is 90% full, sort of, it's not going to happen to most of my patients. And we proceed with myeloma therapy, right? But, you know, when it happens, it's awful, right? I mean, I think all of us have had that experience like as treating physicians. And, you know, when a patient who's in remission from their myeloma develops secondary leukemia, it is heartbreaking. You know, we pay pretty close attention. There's a lot of research right now on predisposition to developing that, either because of like abnormal clonal cells in your stem cells compartment, like before you even start, or the therapy, you know, like the duration of therapy being used with it. Lots of work in this field. Lots of, you know, we're, you know, doing work to try and reduce that risk. You know, we have a researcher downtown, Dr. Bala Subramaniam. He's very interested in this question, among others. He has a clinic called a CHIP clinic, where he's looking for evidence of clonal abnormalities in the stem cells, like out of the gate, you know, as a risk factor for developing leukemia or other conditions down the road. You know, so there's work being done there. But it's real. The other thing is, you know, I think we're refining therapy. So like, for instance, there's a newer generation of drugs that have the same target as Revlimid. Cereblon is the target. And these newer drugs, the way they target it, because it's more specific, it's predicted, not yet proved, but predicted that the second cancer risk probably isn't going to be the same. It's probably going to be lower with these newer drugs, where we're more selectively targeting the myeloma cells without the off myeloma effects that lead to things like second cancer. So we'll see. I mean,
So when you go in for a monthly oncology appointment and a blood draw, are those indicators detected, like for AML or leukemia or whatever, in the typical?
we check. Yeah, we check. I mean, that's the main thing when someone's on maintenance therapy, right? The main reason we do blood work is to make sure you know, that it's safe to continue the therapy and that there's no major side effects happening, right? We you know, in my patients who are on maintenance therapy, I mean, I check their lab work monthly to make sure their neutrophil count's okay, their platelet count's okay, their kidney function's okay. I don't check their myeloma labs monthly. I check their myeloma labs every 2 to 3 months. You know, when they're on studies, their myeloma labs get checked monthly. Studies always demand that, but in off-study practice, I think every 2 to 3 months is a reasonable interval to monitor the myeloma. Yeah.
As a follow-up to that, are there a lot of other treatment agents that are given for other types of cancers that can lead to myeloma? We have someone who's had 7 cancers over 10, 12 years.
Myeloma as a secondary cancer, there are publications which talk about the co-occurrence of, you know, different, you know, so like. I don't know if it's the treatment or if it's a predisposition to both cancers, maybe is a better way to put it. So like if you look at the incidence of myeloproliferative disorders like CML and polycythemia vera and essential thrombocytosis, when you look at the incidence of those in myeloma patients, it's actually a little higher. Like there's something there. As a second cancer, the way like leukemia is a second cancer after getting like high dose melphalan, not really.
Is myeloma?
Not specifically for myeloma.
For her.
Yeah, not specifically. Yeah, I have a patient whose myeloma was his fourth cancer. And I kind of assumed we'd be dealing with multiple cancers throughout his whole illness, and so far myeloma has been it's his latest and last cancer so far, and hasn't developed any other cancers. But I was honestly, he clearly has a predisposition to developing cancer, and we've never been able to find a specific gene that would have predicted it. And myeloma is not generally part of any of the inherited cancer syndromes, like the BRCA and all that. Like it's not part of those.
So because of those risk factors with the secondary cancer, is there a time frame of being on maintenance?
Right.
So is it 5 years and then all your ducks are aligned? And you're in remission, you're doing well. After 5 years, can you go off of maintenance?
So you need to be a member of our research team, clearly, because that's exactly.
Qualification of Dr. Cole.
Yeah, this is exactly, so
Pretty educated.
there's a lot of work in this exact question, right? Could we hit a sweet spot where, we can stop therapy after a certain length of time, not have it translate into like inferior myeloma outcomes, but maybe improve reduce the risk of second cancers. Like that's, or eliminate chronic diarrhea and fatigue and, right. So lots of interest in this question. This is where I think the MRD testing right now is driving a lot of that research. There's a lot of a lot of studies looking at, well, there's two ongoing important studies looking at the duration of maintenance therapy that have not reported out yet. There's a study that we were part of that looked at carfilzomib versus Revlimid based induction therapy, which showed no difference for what it's worth. We know that part, but then there was a second question about the duration of maintenance, and that's still brewing. Still 8 years later, we're still waiting to hear the answer to that. And then there's another big study, the S1803 study called the Dramatic study, and it's basically a randomization between Revlimid and Revlimid Dara as maintenance. And there's an MRD question built in where if you hit MRD negativity at a certain time point and you have no detectable disease, there's a randomization to two different strategies at that time, if you're MRD negative. If you remain MRD positive, you just continue therapy. That's the way the study works. So yes, we're looking at, just finite versus forever as a general strategy, but we're also looking at using response along the way to help sort patients into patients who might be good candidates for stopping or not. So remains to be seen, but this is a huge area of research right now in myeloma land. Questions on the screen. Remain vigilant with mask wearing in public places, dining out, private homes, travel. So this is actually a really, really common question. And the answer is, the prevalence of COVID specifically and other things like RSV and flu varies at different times of the year. For RSV and flu, it tends to be very seasonal, but for COVID, it is not quite seasonal. It waxes and wanes, and they generally see the peaks and troughs coming, ahead of time, but it's not necessarily seasonal. Masks like the ones, like plain old surgical masks like everybody was wearing are somewhat useful when everybody is wearing them. When you're the only person in a closed space wearing it, it is a lot less helpful. It's not nothing, but it's not the same as wearing like an N95. I generally tell, so when I have an immunocompromised myeloma patient, the one setting where I suggest people mask back up with an N95 is air travel. Honestly, I mean, you're locked in a tube with 300 other people and nobody on the plane except you is wearing a mask. And so an N95 in that setting seems like a reasonable intervention to me. But again, it's one thing to wear an N95 when you're flying to Florida, and it's another thing to wear an N95 if you're flying to France, right? It's pretty hard to have an N95 mask on for 8 hours or 12 hours, right? So I think, public, being out in public, being unmasked, being, as vaccinated as you can be, there's a calculated risk to it, and that's, it's still, I still find it to be a hard conversation with patients. It's the best answer I can give on that question. In terms of wearing masks around the house and things like that, I mean, I don't think there's any utility at all to that. I mean, I think telling people who are visibly sick not to come over makes sense. But there's not, minimally symptomatic or asymptomatic people who are COVID positive. It's going to be pretty hard to avoid that, fortunately. All right, we have another question from Nancy Katz. 109 days from transplant. 2 weeks ago, hives, rash, face, and neck. Any experience with this? Got your own stem cells, and I assume you didn't start maintenance therapy. Nancy, I assume you didn't start maintenance therapy at day 90 or day 100. You're still on no maintenance. Nancy, maybe on mute.
I am starting maintenance at the end of May.
So you just started having hives now?
Yeah.
I'm not, I don't know.
I just thought I'd ask the question because no one seems to really know what it is. I'm just taking Claritin, and the doctor wants me to switch to Zizol. Yeah, we've done testing with going back on losartan because that can cause rash, but that wasn't it. I've taken out all nuts. That doesn't seem to be it. So that's why I was just wondering if you've ever had experience, because nobody knows what this is. It could be stress. I don't know.
Yeah, I haven't seen that happen. I'll tell you that in a non-transplant setting, viral infections as a cause of otherwise unexplained hives is actually not that uncommon at all. And I don't know if you feel like you've been fighting anything off at all.
No.
But if it's somehow related to that, it should be self-limited. It shouldn't be a permanent ongoing issue.
Okay.
The other question to look at is maybe the preventative antibiotics the transplant team has you on. If you're on sulfa or acyclovir or some other med, trials off, brief trials off of those to see if the hives resolve. You could probably get away with without running into too much trouble.
Thank you.
Elizabeth Hansen has her hand raised.
I had to unmute. I had a question about, well, I'm on maintenance right now. And actually, when I first got my multiple myeloma in 2020, I had this group, I came to this group and everyone convinced me to get a second opinion. So I went to you, doctor, for my second opinion a few years ago, you know, and I'm in Chelsea, so I come out of the Chelsea Hospital Cancer Center, and I'm on maintenance now. I've been on maintenance a couple of years, and this year, starting in January, instead of going once a week, I go every other week now for my chemo, and I get Velcade 1.324 milligrams, which is pretty low, I think, isn't it? 1 point.
Well, yeah, I mean, if you're average size, that's a pretty low dose, yes.
Yeah. And so far it's been working really well at that dose every other week. So Dr. Beekman has been, you know, like I said, through the years, lessening everything, and everything has been holding up. I had a very bad with the amyloid on my heart, my kidneys. So my heart, my kidneys are severely damaged. And my question is, does the multiple myeloma eventually, could it just go away, disappear?
Yeah, it's pretty unusual. I can count the number of patients I've had over the years on one hand who seem to have had a spontaneous regression of their myeloma. I have one patient who I still like. I cannot explain what happened with him, and he loves that. But you know, a patient who, you know, had a new plasmacytoma develop. This is a person with established myeloma. New plasmacytoma develop on his sternum, and his numbers were worsening. And so we scheduled him for restaging, a PET scan and a bone marrow biopsy. And even by the time he got to the bone marrow biopsy, his numbers were getting better. And by the time he got his PET scan, his sternum had actually flattened out again. And it was biopsy proved. I mean, we knew from a biopsy that it was a plasmacytoma. And the staging was better than we expected, and his numbers improved again. And he hasn't been on therapy for years. I've just been watching him off therapy. So I mean, you know, I think the immune system, I think we know from CAR T cells and bispecific antibodies, you know, that the immune system or other factors can control myeloma. I mean, so is it, you know, it's not unheard of, but it's rare enough that it ends up getting published as case reports. I'll tell you. I mean,
Will the amyloid eventually come off my heart and kidneys?
So for people who don't on the call who don't know, so amyloid is protein deposits in the organs. In the case of myeloma patients, it's protein deposits in the organs, and these deposits are the light chains that the myeloma is making. And the light chains misfold and get sticky, and they form these deposits. And the symptoms of amyloid depend on what organs have these deposits in them. And it adds a whole extra layer of challenge, as you know. It tends to make patients who have coexisting myeloma and amyloidosis very fragile because of heart and gut and liver and kidney involvement. And you know, the way we treat it is we treat the underlying myeloma, and by doing that, if you can shut the light chain production down to normal levels, then you deposit less, you make less protein deposits going forward. So it slows that down. And then if you can do that for long enough, in many cases, your body will eventually start to clear these deposits out. But the frequency that happens in the best studies varies from 50 to 80%. So a significant number of patients still have whatever deposits they had, you know, after you've done treatment, and the deposits stay. Also, sometimes the deposits do get smaller, but organ function doesn't recover completely. And so, you know, you maybe have a 30% improvement in heart function or a 25% improvement in kidney function, but it doesn't completely normalize. But that's the main strategy right now. There are several companies that are doing studies with antibodies that target the protein deposits. So instead of using an antibody that binds to the plasma cells and kills the plasma cells and then indirectly makes the light chains lower, they're actually antibodies that just stick to the protein deposits. And when you coat the deposits with antibodies, your immune system can find those deposits more easily, and then you can clear it better. And so Karmanos has actually been involved in about 5 studies of these over the years. Right now, we have three open. 2 of them have finished putting new patients on, and we're following the patients on study. And one of them is still accruing patients, but these are for newly diagnosed patients whose symptoms are related to amyloid. If these studies work, then we will have a new tool to help get rid of amyloid in organs.
I know, because Dr. Beekman told me the chances is that she doesn't think the multiple myeloma is going to kill me. She thinks it's going to either be my heart or my kidney that has been damaged so much by the amyloid. There's going to be my greater risk. So it's really tricky. You're right. And I was hoping that maybe there will be something for me.
Well, I mean, if any of these studies are positive and we have these antibodies approved, I can guarantee that they will be rapidly explored across all of these different types of situations. Right now, they're just trying to do a trial that proves it removes amyloid in some people and improves outcomes. The way these trials are all designed right now is they're targeting patients with really advanced heart involvement by amyloid, because it's, as your doctor has told you, you know, it's those are high-risk patients, and it should be easiest to prove if there's a benefit in that group. So that's what we're working on.
Thank you.
It's our last question.
All right, last question from Karen. Should myeloma patients get colonoscopy at later than usually recommended by age? No. You know, I think colonoscopy screening, right? I mean, you have to think about whether it makes sense to do it in the context of what's happening with the myeloma, right? Even in the general population at a certain age, you know, colonoscopy screening, becomes less important because of the, competing health risks. But, if you're 50 years old or 55 years old and diagnosed with standard risk myeloma, and you're likely to live a long time, some period of time, hopefully measured in decades, right? I mean, you should have cancer screening, you should have mammography and pap smears and colonoscopies and usual cancer screening. I mean, if anything, your risk of second cancers is, as we talked about, a little bit higher than average, right? And so, if your expected survival on average from where you are at that moment exceeds the period that a screening test is being done, to screen for, then it makes sense to have the cancer screening. There is a little bit of variability in opinion about this, and there are some, I know some good myeloma doctors who really are nihilistic about cancer screening for other cancers. I am not in that camp. My feeling is, it's tragic when a myeloma patient who's responding to therapy gets secondary leukemia, and it would be, in my opinion, equally tragic if a myeloma patient who had a polyp that could have been removed 5 years ago develops colon cancer. That's also a misstep, right? So you should have cancer screening. Yeah. I think that's our time, right?
And we are beyond our time. Thank you so much for your time.
Yeah, they went tired.
Just a reminder of our upcoming events on the screen. Also, if you're interested in being on the Carmano Support Program, email list, email hardyk@carmanos.org. As always, you can see these discussions a few days after we've had them via YouTube through our website at curemultiplemyeloma.org. Thanks again, everyone, for attending. Remember, Wine Dine is D, November 6th. And again, thank you to our event sponsors. Have a great afternoon, everybody.